Hello, everyone. Welcome to our discussion again. Today, we are going to talk about outcomes of physiotherapy, or in general, rehabilitation outcomes. Right. So, outcomes are what is commonly referred to in a clinical setup is the effects of treatment. So we will use these terms interchangeably, whether effects or outcomes, right? So when it comes to effects of a treatment or outcome of a treatment, right? Uh, how should we determine this? That's an important question, because often it leads to confusion of some says it's effective, some say it's not effective. So we need to define when we say something is effective. Now, effective in what? So for that, we need to define what outcomes should improve so that we can say a treatment is beneficial, right? So as usual, we have Mr. Hariom with us. Now, what do you think is the outcome of rehabilitation or physiotherapy, to be specific?
I think we have already talked about this. I suppose it should be meaningful for our
Yeah.
patient. It should not be some laboratory test or some biochemical test, which may be important, but that's not the real outcome we are looking into. So I think the real outcome should be the patient's experience of overcoming whatever reason they came to you, whether
Uh,
it is living for
yeah.
long without disability or overcoming disability or overcoming all those things.
Why do you think measurement of, say, for example, range of motion, joint stiffness, and these impairments are not as outcomes? Because that is what we commonly measure, and changes in it is often perceived as effect of a treatment.
One of the things which we understand now very well is if these things changes, that is your range of motion or your spasticity or your tenderness, whatever it changes, uh, it does not seem to be proportionally changing the uh, realistic outcome or the meaningful outcome we have been talking about. That is the patient's disability or pain or overcoming the disability. It doesn't change uh, linearly because we know that the biological systems are far more complex,
Yeah.
and most of the time they change non-linearly in the sense that not scaling proportionally.
Right. So your what you're pointing is that changes in the impairment or the biological factors, that is that's physiological factors, need not necessarily lead to improvements in patients' functions in daily life. And I
Right.
think the other way is true, is that patient may improve without any changes. I mean, may improve in their daily activities without any actual changes in the impairment, isn't it?
Correct. Correct. That's where we are mostly stung. We think that how can that be possible also, that
Yeah.
something else has changed, but nothing. There may be many number of factors for that. One is the system is not the underlying all the factors we are unable to measure or even know the factors. And also there are a lot of factors which we may never be able to measure,
Yeah.
especially when the property is emergent. It's not possible. It may not be possible for us to ever measure it also.
Right. I think the disability is what patients experienced. It is in a real life context.
Right.
When we talk about real life context, it is where the biological factors interacts with the physical, psychological, and social environment, and then the output is the disability experienced by it. So that interaction is, that's what I think you're referring to as emergent. When it
Yes.
interacts, what comes up. And by changing only one component of the interaction may not actually produce the outcome. Not, we have lots of evidence showing that it is not actually changing. Can you give think of an example where changes in impairment doesn't change the disability?
Uh, the whole Paralympics is it's a huge in-your-face example of
Yeah,
what can be achieved with adaptation.
yeah,
That adaptation comes with when you put the patient or when you put the participant in a context. They
exactly.
emerge and adapt, and they do things which are unbelievably
Yeah, especially
beautiful, right?
these athletes are what we call having a permanent disability, isn't it?
Yeah, it's not like they have chikungunya like me and unable to walk or something like that. They really have poliomyelitis when they were small to didn't have spinal cord injury, which is irrevocable,
Right,
that kind
right.
of thing. So that's a, and also the whole idea of measuring. When we measure, we cannot measure with the context. That's
Yeah, yeah,
fairly difficult to
right,
do.
right.
So when we leave out the context, the emergent property is lost. So it's not, that's why we, most of the time we are unable to clearly predict as well as clearly know that the underlying things are changing. What are the things that are changing and things like that.
Maybe the often talked about advances in physiotherapy, I think it has to come there where we'll be able to measure outcomes in a real life context. So, whether it's technology or some other means.
Very, very true.
Yeah. One of the reason I think this contradiction exists among physiotherapists is, again, this is my personal opinion, that physiotherapists often does not recognize themselves as a rehabilitation professional. They tend to identify themselves with other health professionals, say, for example, other medical professionals, where they work on changing a symptom or pathology, rather than physiotherapists who would work on rehabilitation.
Uh, uh, Even in medicine, I think changing a biochemical parameter or surrogate parameters, it's just utter nonsense. I think this is not a problem in physiotherapy alone. I think it's a problem in the whole of medicine.
All right. All right.
So we have this
So rather
tradition
than
which we are unable
rehabilitation,
to.
we would say as overall the medicine itself is the problem exists, where they don't see outcome from the patient's perspective.
Yeah, because also medicine is highly paternalistic. I tell you, you do what
Yeah,
I'm
yeah,
saying.
yeah.
If you come with reading the Google, I will charge you more. That kind of idiocy is considered as though it is very proud to be put in a sticker on the waiting room, as though we should only listen to somebody who has 7 years of education. Other people are, we are only fit to just listen to them. That kind of nonsensical paternalistic view is what is stopping that also, I think.
Right. So moving on, I think we have fairly established the outcomes, why it needs to be on what patient wants change. And in a current scenario across the globe, there is a consensus. It's not just our personal view, that even clinical trials of drug clinical trials, now the regulatory authority insists that that should be patient reported outcome measure, and it should be the primary endpoint. That is, it has to be the primary outcome measure. Other surrogate measures such as biological or what is referred to as biomarkers are only considered now as a secondary outcome measure, right? But
Right.
unfortunately, in physiotherapy yet, especially in PhD, that there are a lot of people tend to think that having biological biomarkers is what is giving them sort of high quality, hi-fi research. And if you use a patient report outcome measure, people looking down on it, saying that this is subjective. If I would really want to look up on them to ask them to, get to the patients.
Uh, Once somebody told me that they are going to see the gene expression after ultrasound, I was like, what? so, the people think that if you measure something in the laboratory, it becomes more reliable. It becomes more something more than the biological.
And it sounds
something
sort of you're doing some serious research. Hi-fi.
Yes. So there's a place for that.
Yeah.
Molecular biology or primary science, they do those things. In a clinical research, it doesn't make any sense because that's just a change in the biomarker. That's not a change in the human person.
Yeah. So the point what I'm trying to get across is when it comes to measuring outcomes, whether especially in research, researchers have to understand this is that we are doing research to solve patients' problem. That's why we are doing research. So we cannot simply say that the conceptually the ideal outcome has to be that patients are doing better. There is no point in saying, you take a blood test and say that blood sugar level has come down and what, so on and so forth. That's just, I think it's a poor understanding of even the medicine or even basic physiology, where we get to blood reports rather than, or X-ray or MRI, rather than look at the patient who's right in front of you.
We used to have this joke, surgery was successful, beautiful, but the patient is dead, right? So this is what happened during COVID times. It improved blood oxygen level, PO2 and things like that. But what happened to the patient? They also died at the same rate as the other treatment. So, so the living of the patient, living without disability, is what is important more than anything else.
All right. So moving on, we've come to the final section of our discussion. Let us assume that some of the clinician researchers have convinced with our discussion, and they want to know, so how do we go about it, right? So what should they measure? What tools that they have to use to measure?
This is slightly tricky because a lot of things, what we would like to measure, the standard tools, most of the time they don't capture it. So find something which at least capture to a certain extent.
Goal attainment scale, we can start off with.
We can, but I'm just talking about the standard scales first.
Right.
Choose something which is similar to what
at least
you
we would
think
say 75% of the items are somewhat relevant to our context. Expecting 100% that present may be too ambitious, but
correct. Say for example, OMAC for OA&E looks okay. It may not be the best or the worst. It's a good scale.
For low back pain also we have the ODI that also looks reasonably good.
Yeah, even the Ronald low back scale,
Roland Morris.
These are okay. They are not ideally the best, or it's not the worst. It's okay.
And also they all are developed slightly like 10 years ago, so there's quite a lot of changes come in our understanding.
Probably, no, it should be more than 10 years. It should be, I mean, that should have been when I was in college. So, well, the next thing, as you have pointed out, I do like goal attainment scale. It has its own issues with it. A lot of people I have tried out, or they have difficulty in moving it to from 1 to 2, or I mean, moving the scale. They have some issues with that. You have to talk with them to make them understand, and because it's not just you or I moving it, we have to combine and move the scale. So goal attainment scale is a wonderful idea, and for a lot of things we need to I wanted to emphasize this point. We suddenly seem to be translating whatever scale comes in our way into regional languages, thinking that that is the solution. I think that's not a solution.
Right. So let me end this conversation with one real life example of what looking outcome from a patient perspective. I was treating a patient with stroke, and I mean he's having mild to moderate stroke, and he is having a certain upper limb problems and so on. But one day he is recovering well. But one day he was so happy that when I asked, so what made you so happy that you think the treatment is working? And he was saying that today my check is passed by the bank manager. He said that's all right because he is able to put the signature. Now, we can never think of this as an outcome from, I don't know, from physiotherapist can, at least I couldn't think that as a really, really important outcome. But the patient sees that that is getting his life back in its own way. And it's really, really meaningful. He can put a signature that's accepted by the bank.
And also, it sort of tells you that he is independent financially.
Yeah. Yeah.
So I think I think one of the outcome scales in upper limb has writing check as a outcome, I think.
Yeah. Oh, okay. You have any final thoughts on it?
Yeah. So I just have only one thought. Don't worry about having a standard scale. Worry about what is important for your patient. Afterwards, everything will fall into place.
All right. On that note, we'll end this discussion. We will come up with something more meaningful and relevant, I hope.
Okay. Bye-bye.